So good afternoon, everyone. I am really excited to be here and would like to thank the conference organizers for inviting me to talk about academic community partnerships for precision medicine. It's really great to be here because one of the roles that I play at MUSC is a director for the Special Populations Corps, along with my colleague, Dana Burchell. At MUSC, and so we work really closely with our community engaged scholars program to think about issues related to inclusion and diversity. What I wanted to talk about today, though, was the work that we've been doing within the context of precision medicine and academic community partnerships, and really frame this within the context of our Transdisciplinary Collaborative Center for Precision Medicine and Minority Men's Health. It's actually, I think about it as a very large academic community partnership. So we actually have some of the same slides, so great minds think alike. I think one of the things, as you were talking, my birthday was last week, so exactly 1 week ago, so we're all on the same page. But I wanted to just say that I would echo the comments that were just made, because I do think we're at a very critical point in healthcare and healthcare delivery, with the opportunity for precision medicine to really promote equity by providing individualized strategies for early detection, prevention, and treatment. And the All of Us Research Program, again, great minds thinking alike, I think is a really great opportunity that builds on the forethought that NIMHD had in terms of active community engagement, meaningful community engagement, and the research program. When I was at the University of Pennsylvania, we were really fortunate to be one of the centers funded through this community-based participatory research program at NIMHD. And we really thought about that as we developed our Transdisciplinary Collaborative Center in Precision Medicine and Minority Men's Health. And one of the first things, as you all know, that we want to start with issues and topics that are relevant for community organizations. So as we thought about building our TCC, we wanted to build a regional consortium that supported active engagement of academic community stakeholders and public health stakeholders in precision medicine and health disparities research. And as part of that, really engage collaboratively across a multi-regional consortium in our translational research efforts. We really wanted to think about and develop and implement strategies for dissemination and knowledge translation to facilitate implementation of best practices of precision medicine approaches. So I wanted to tell you why we decided to focus on minority men's health within the context of health disparities. I mean, we've heard about that over today about disparities. From our keynote speaker, we heard about the disparities that exist. We focused on minority men because as we thought about it and did a landscape of the research in this area, that minority men were really underrepresented with respect to the larger health disparities research agenda. And we felt that it was time to take a stand and really engage and develop and conduct transdisciplinary research that addressed some of the pressing issues that face minority men, heart disease, stroke, diabetes, and HIV as examples of some of the disparities where we see particularly striking disparities. So, one of the things I think that I learned working as part of the West Philadelphia Consortium to address disparities is that it really does take a collaborative effort. And the TCC approach, I think, really pushed us to move beyond sort of a citywide perspective, to think more regionally in how we addressed minority health and health disparities. So as you can see here, we brought together several different types of academic institutions. The University of Pennsylvania, Hampton University, which was leading a transdisciplinary collaborative center in minority men's health, and had a focus on chronic disease prevention. The University of Texas Health Sciences Center in San Antonio has a focus on minority health from the perspective of Hispanic population. So we wanted to be inclusive from an academic side, but also engage diverse types of community-based organizations. So we brought together the Low Country Area Health Education Consortium, which is our AHEC in South Carolina, but has a regional, a national outreach approach. We also continue to partner with the National Black Leadership Initiative on Cancer and the Hope Institute, which is based out of Baltimore, Maryland, which focuses on ethical, legal, and social issues with respect to inclusion and diversity in clinical trials. And then lastly, we're partnering with the Southeastern Health Equity Council to think about, again, from a regional perspective, diversity and disparities issues. So some of the things I'll just take a note. We built upon the base that we had established with our academic community partnerships through the work in Philadelphia and expanded that in the model that we implemented in South Carolina through our TCC in Precision Medicine and Minority Men's Health. So thinking about the work that we're doing within our research projects, we thought about this also and needing to have multidisciplinary investigators in a leadership capacity across our center. And what I'm showing you now is just that we have a very diverse group of investigators who are actively engaged in our center leadership. So it includes medical oncologists, geneticists, bioinformaticians, nursing science, and individuals with expertise in dissemination and implementation science. Our overarching framework is shown here. So I was really excited to hear the concept of stress and stress reactivity mentioned in the keynote address, because we know as we were thinking about our application, one of the things that became really apparent to us is that there are some unique stressors that minority men face, both acute stressors and chronic stressors. We also know from the literature that stress and stress reactivity impacts the initiation and progression of disease. And we were interested in thinking about, well, how can we use that? How can we use established markers to understand biological functioning? So that's really the overarching framework of our centers, to understand allostatic and the allostatic process and how it influences disease initiation and progression. And so when we thought about diseases, we know that there are many conditions where disparities exist. Some of the things that we thought about in focusing our initial center work was that we wanted to focus on a condition that had a significant clinical and public health impact, and was also a condition that was relevant for community stakeholders and individuals in the community. And then we also wanted to understand diseases that had biological, clinical, and public health relevance to other chronic conditions. So as we thought about this, and we, again, building upon the work that we and others have done, and it led us to focus on prostate cancer as part of our initial center focus. So as you can see here, we've looked at utilization of prostate cancer screening among African American men and found that although there's a recommendation that men engage in an informed decision-making process, that really doesn't play out in terms of how men are making decisions about prostate cancer screening in our work, as cited here. And then we also know, if you think about the continuum from screening to diagnosis to treatment, that there are differences in quality of life following prostate cancer diagnosis, and that those differences are influenced by men's social cultural factors, so their beliefs about religiosity and temporal orientation as being important to how they react to their being diagnosed with prostate cancer. And then we think about the context of minority men and being included in any type of study, but particularly when we think about participation in genetics research, that there's a wide range of level of intentions and interests. Some of my early work focused on genetic counseling and testing for inherited breast cancer risk. And so we were thinking, and one of the challenges we experienced was making our information available to women across diverse settings. And so we wanted to understand intentions to donate to biobanks and intentions to participate in precision medicine research. And you see that from the two examples here shown from our own work, that there's a lot of variation, that if you ask individuals if they would be willing to participate or donate to a biobank, that about 23% said that it was very likely. But if you ask them and give them more information about the attributes of the study, what it would actually involve in terms of their participation, that it's much less likely, only 31% saying that they would participate in a study that was sponsored by the government, where they had to give a biospecimen or complete a survey about their personal and health history, and that they would not get results back. So again, if you provide more information about the research, we see a less willingness to participate. So I'm really excited to see some of the work that you're doing to engage populations in the Oliver's research program. This just shows you an overview of our center projects, again, focusing on stress and stress reactivity and how it affects some of the critical junctures within the trajectory of being diagnosed and treated for prostate cancer. And what I want to now share is how we're organized, because I think as I've been working within the context of academic community partnerships and some of the last work that we've been doing in Philadelphia, one of the things that I've been realizing is that it really does take a lot of forethought and effort to organize the administrative components to ensure that there is a broad strategic oversight and management of the day-to-day activities of the partnership, to ensure that things are happening as they should happen and that you stay on target. One of my partners when I started out, and this was when I was an assistant professor, they're like, you know, you're such a task manager. How can you be so uptight at such a young age? I was like, well, you know, we've got to keep the ball rolling here. And so that has some advantages and some strengths depending on the context. So what I want to share with you now, sort of the organization of our center, and really highlight some of the roles and challenges that we've experienced, or some, not challenges, but the decisions that we've made along the way. So our consortium core is responsible for the overarching infrastructure that provides the direction and sets the priorities and governance of our center. Some of the things that the consortium core is charged with is working across all of our other cores to implement strategies and develop the research program that addresses the priorities that have been identified with respect to precision medicine. We also have an implementation core that works very closely with the consortium core to develop materials and methods for determining readiness and capacity of different stakeholders across regions to implement and adopt precision medicine approaches into clinical care and public health practice. And then our data integration core is working to integrate sort of on a more detailed level the data that's being generated through all of our projects into so that we can use that information to translate it into effective strategies for precision medicine. So, you know, as we've taken a step back, we're into now our second year of our center. So, and the first year was really spent building the infrastructure, building the administrative components, and making sure that all of our cores and projects had timelines and milestones that were appropriate, that were relevant for the work that we were charged with doing. And as I prepared this talk, you know, it really made me think, well, you know, how do we go about integrating all of these activities to facilitate and make sure that we were engaging our academic and community partners effectively and meaningfully? So one of the things that we did was first just take a step back and think about this within an overarching framework that ultimately we want to develop strategies that can be implemented into care, public health practice, clinical care. And so if you think about this sort of the translational perspective, you know, we're doing work that is interested in, that will understand the ways in which biological factors, clinical factors, and social factors influence the progression and initiation of disease. But ultimately, we want to translate that down into evidence-based recommendations or policy that are implemented in healthcare systems and prevention programs. The first thing we had to do that was for us to sort of to come up with a definition of precision medicine that made sense to us and that guided the overarching work that we did. And you can see here that our definition of precision medicine that we adopted is consistent with the one with NIH, but I've highlighted the focus for us, and that's really to ensure that people receive the right medical care in the right dose to the right patient at the right time. And that really resonated with the academic members of and community members of our consortium core, and has resonated with all of the constituents in each of our core activities and CEnR projects. So we've also worked to establish goals for community engagement. And this was something that both our academic and community partners and our consortium core really felt like we needed to do, so that we had an overarching framework that guided the activities that we did with respect to community engagement. So you can see here that our goals, one, for community engagement, we just don't want to send information out, be sending the information out. We want it to be information that people can use to increase their knowledge, awareness, and their level of being informed about precision medicine, and that they can use that information and develop their capacity to apply it to the decisions that they're making about their healthcare or clinical practice. We also want to develop and engage different stakeholders to ensure that they are able to make informed decisions about their participation in precision medicine research and/or referring members or patients for participation in studies. I think the point that you made about, if people decide at the end of the day that they don't want to participate in a study, they don't want to participate in any activity, that it's okay, that the ultimate goal for participation is that people have made an informed choice that's consistent with their knowledge, beliefs, and values. And then I think most importantly, what we want to be sure that we do as an ultimate goal is to ensure that the use of precision medicine doesn't result in exacerbating racial and ethnic disparities in healthcare and outcomes. And I think that precision medicine, if we're at a really critical juncture where we have to start thinking about ensuring that information and knowledge is disseminated across diverse settings. One of the things that we know is that there's some very complex genomic strategies, but every group will not be able to implement those very complex strategies, but they need to know how to refer people and refer patients so that they are able to access those things, so that it doesn't result in sort of the haves and the have-nots. Some of the things that we have started to do is we will I guess as a behavioral scientist, I cannot resist the temptation to do a survey, but I think it's important within this context because one of the things, just as we've been thinking about precision medicine, we've had a series of conversations about, well, do people really understand what precision medicine is? And, if you say precision medicine, when I think about it, it means one thing. When you think about it, it means something different. So I do think there's an opportunity, and it's important to understand, well, what do people think and know about precision medicine? And what are they concerned about, and what are their preferences for where we would focus our efforts initially and over the longer term? I think it's really important to understand organizational capacity for precision medicine. And we've been thinking about this from the perspective of, if you're a primary care provider, your role in precision medicine may be a little different than if you're at an NCI designated comprehensive cancer center. And so we want to understand the roles and responsibility and capacity that different types of organizational healthcare settings have for precision medicine, so that we can understand what resources are needed and how ready they are, and what types of activities need to happen to increase their readiness. Our last engagement strategy is something we're really excited about. It's an evidence academy, and an evidence academy is an approach that one of my colleagues, Kathy Melvin at MUSC, has developed with colleagues at UNC Chapel Hill, that focuses on knowledge translation for the purpose of developing tailored implementation strategies. And so I think there are lots of examples where there have been policy recommendations passed down from, I call it on high, but from the policymakers like CMS and others, where, you know, it's like there's a really great policies, but when you think about how you implement that in a busy clinical practice, there's sort of like a disconnect between where the rubber will actually meet the road. And so the Evidence Academy is really structured around sort of a co-learning process where individuals sort of present their understanding. We bring everyone to sort of a same baseline understanding about a particular issue, and then work to develop best practices that are realistic for their particular type of setting. So we're doing that through regional implementation teams, which we've developed into to be composed of individuals, different types of stakeholders who are critical for adopting precision medicine. So it includes healthcare providers, community public health officials, as well as individual patients. So these are the things that we will be asking them to do over the future years of our center. So we're really excited about that. And the first thing, we'll bring them to our Evidence Academy, which will be held November 16th to sort of start our work with respect to dissemination and implementation. So I thought I would conclude by just sort of sharing some thoughts. One is, you know, as we've developed our regional implementation teams, we've thought very carefully about, well, who are the right stakeholders who need to be engaged in this conversation at this point? I think one of the challenges with precision medicine is that it is emerging, and that we have some things that are, it's a work in progress. And so the actual clinical implication is being defined. I like how you described it as a plane that's being built, and we're flying it now. So determining who the right stakeholders within that context has been a little challenging, I must admit. The other thing that I've learned over the years is, well, when and how do we expand our partnership, and when do we limit participation? We have a very effective working group partnership at the moment. But as we've been thinking about this, you know, one of the things and the decisions we'll have to make is, well, when will it be time to expand our partnership, and when will we need to sort of bring it back in to keep it more precise? I guess some pun intended. The other things that I think about is, you know, as we talk to community stakeholders and lay patients in different healthcare settings, you know, I always come back to this issue of precision medicine versus basic healthcare services. And, you know, one example that comes to mind is, you know, when hearing about the latest in exome sequencing and genome sequencing, you know, those are really, I think, very specialized services. And I think we want to be able to develop and implement strategies for precision medicine that really enhance basic healthcare services and really facilitates access to some of the basic and addresses the basic healthcare needs. And the last point that I'll make is, you know, it's been, you know, thinking about the structure for our consortium, it has been really critical to have a very strong administrative team that works to coordinate and integrate all of the activities across our different cores and research projects. And I'll end there, and so maybe that'll be a point for discussion.
Thank you.
Yeah. Thank you.